Hi everyone, Nurse Jenny here from Nurse Life Academy, and I'll be reviewing respiratory questions and concepts that you must know for the CCRN exam. The entire respiratory section will be covered in 2 parts, and this is part 1. I will time mark this video, so feel free to just scroll through at your own pace, but I do give extra information and explanations after every question to really reinforce the content. Keep in mind that this is just a review, so if there are things that you aren't familiar with, go back, review the information until you feel comfortable and can answer these questions correctly, because these are questions you want to have mastered before going into the exam. I would greatly appreciate if you like and subscribe to my video if you found it helpful, but also so that you can be notified of new videos that are dropping. Now let's get started. Question number 1. You have just assumed care for a patient in acute status asthmaticus. You know that the first line treatment is A, a beta-1 agonist, B, a beta-2 agonist, C, a beta-2 antagonist, or D, a corticosteroid. And the answer here is B, a beta-2 agonist. So remember, 1 heart and 2 lungs. So we want to stimulate the beta-2 receptors, which open up those airway smooth muscles. So we're going to give beta-2 agonists as our first line treatment. What's an example of a beta-2 agonist? Bronchodilators, such as albuterol. Let's go through a quick rundown of status asthmaticus. So status asthmaticus is a medical emergency which is characterized by airway hyperactivity, severe airway narrowing, thickened secretions, and air trapping with lung hyperinflation, and all of this is refractory to aggressive bronchodilator therapy. And there's generally some kind of exposure to either an allergen or a trigger, such as a viral infection, maybe cold weather, or some kind of environmental allergen, which leads to this continuous bronchospasm and airway restriction. Some clinical signs include dyspnea, tachypnea, accessory muscle use, anxiety, and tachycardia. And when it comes to lung sounds, at the onset, the patient will be wheezing, and this is a good thing in this scenario. But as they slowly tire out and develop worsening respiratory failure, their breath sounds are going to decrease and eventually become absent, which is an ominous sign. So if you have a patient in status asthmaticus, you would absolutely rather them be wheezing away than not moving any air at all. And similar to the breath sounds, you will see a progression in the ABG results. In the beginning, you'll see respiratory alkalosis in the early failure when they're hyperventilating and breathing off a ton of CO2, and then you'll end up seeing respiratory acidosis in late failure, where their level of consciousness is decreased and they are not moving air and retaining CO2. So how do we treat these patients with status asthmaticus that are refractory to aggressive bronchodilator therapy? Well, we usually will intubate them if we see severe respiratory failure, respiratory acidosis on an ABG, or a decreased level of consciousness. And then once the patient is vented, they will need specific vent settings, including a low respiratory rate, and that's to increase their exhalation time. These patients will need low tidal volumes to prevent auto-peeping, and auto-peeping is just a sign of air trapping and not full exhalation prior to initiating the next breath. And we'll also have to increase the IE ratio, or the inspiration-expiration ratio. Again, this is to allow time for proper exhalation and to prevent auto-peeping. When it comes to pharmacological treatment, our first line is going to be bronchodilators or beta-2 agonists, such as albuterol. We can also utilize anticholinergics, such as ipratropium, corticosteroids. And lastly, we want to keep these patients hydrated to prevent thickened secretions, but also due to their insensible water loss from their tachypnea. Question number 2. The following ABG is an example of a pH of 7.19, PaCO2 of 66, PaO2 of 68, and an HCO3 of 30. Is this A, partially compensated metabolic alkalosis, B, compensated respiratory alkalosis, C, partially compensated respiratory acidosis, or D, uncompensated metabolic acidosis? The answer here is C, partially compensated respiratory acidosis. I have this slide here as a quick review of normal values and which values are considered acidotic and which are alkaline. If you do not have these memorized, you need to. Right now, we're only going to focus on 3 of these, so our pH, PaCO2, and bicarb, because these are the values that we'll be looking at when we interpret our EBGs. Now, a normal pH is 7.35 to 7.45. pH is considered acidic when it's less than 7.35 and alkaline when it's greater than 7.45. A normal PaCO2 is 35 to 45, and since carbon dioxide is an acid, when PaCO2 increases above 45, it is considered acidic. And when there are low amounts of CO2 under 35, it is considered alkaline. A normal bicarb is 22 to 26. And since bicarb is a base, if bicarb is less than 22, it is considered acidic. And if there is an excess above 26, it will be alkaline. You have to commit this to memory. One extra side note here before we move on is that our bodies love balance, they love homeostasis. So when there are changes on one end, the body will usually compensate on the other end. And the lungs are going to be the quickest to compensate, while the kidneys will be a little bit slower to compensate. Okie dokes. So we know our normal values and when they trend high and when they trend low. So let's put it all together. And I like to think about acid-base interpretation in 3 steps. So we can kind of look at it as a first name, a middle name, and a last name. The first name is going to be your level of compensation. The middle name is respiratory or metabolic. And the last name is either acidosis or alkalosis. I know that there is a lot on this slide, but let's go through this together with the example on the bottom here. So remember, first name, middle name, and last name. We're going to start with the pH, and let's make this super easy for ourselves. So we're going to ask ourselves, is it normal or is it abnormal? And if you have a normal pH, boom, you're done. Your first name is going to be compensated every time. If you have an abnormal pH, you're going to be uncompensated. And that's all that we're going to fill in for our first name right now. We're going to make it super plain and simple, normal or abnormal, and then we'll determine the level of partial compensation at the end. So let's look at our example here. We have a pH of 7.22. Is it normal? No, it's not normal. A pH of 7.22 is not normal. And because it's not normal, the first name is going to be what? Is it going to be compensated or uncompensated? An abnormal pH will buy you a first name of uncompensated. So awesome. We have our first name. Now let's look at the pH again to figure out the last name. The pH is 7.22. Is this acidic or is it alkalotic? It is acidic. So we have an uncompensated acidosis. We've got 2 of the 3 names already. All we need is just a middle name. This brings us to step 3. So here we're going to look at our PaCO2 and our HCO3 and figure out which one is trending with our pH. In this case, our pH is acidotic. So we want to look at which value is also acidotic. Is it our carbon dioxide or is it our bicarb? Which one of them is leaning towards acidosis? We are going to look for either a CO2 level of greater than 45 or a bicarb level of less than 22, because both of those values trend towards acidosis. And in our example, the CO2 is 74. Whoa, that is way over our upper acidotic limit of 45. So if it's the CO2 that's making the pH acidotic, this is going to be a respiratory acidosis. Our bicarb is normal here, so we look good. So we're going to put our full name together. It is uncompensated respiratory acidosis. You can have a combined respiratory and metabolic acidosis, but that is not tested on the CCRN, so we don't have to worry about that. Let's just practice one more before we move on. All right, let's give this guy a name. So where do we start? We are going to start with the pH. Is it normal or abnormal? pH of 7.20, that is not normal. So our first name here is going to be what? Compensated or uncompensated? An abnormal pH is going to be uncompensated. Okay, so let's figure out our last name. Again, we're looking at the pH. It is 7.20. Is this acidotic or alkalotic? It's acidotic. So far, our name is uncompensated acidosis. Let's figure out our middle name now. To figure out the middle name, we're looking at your carbon dioxide and your bicarb and figuring out which one is trending with our pH. So again, our pH here is acidotic. Which value is also acidotic? Our carbon dioxide, it's 82. That is absolutely acidotic, which means that this is a respiratory acidosis. So we have got it. But hold on a second. I just noticed our bicarb is not normal either. It's not low, so we know that that's not contributing to the acidosis, but it's high. So what does that mean? It means that the kidneys are pumping out bicarb to try to compensate and keep the pH normal, but they're just not working. If this is the case where the other value is abnormal, but it trends in the opposite direction, and by opposite direction, I mean alkalosis, then you change the first name to partially compensated, because we do have to give them some credit for working hard to try to compensate, but it's just not working enough. I hope that this is making sense. I'll have a separate video on just acid-base balance practice, but let's move forward so that we can get through some more content. Question number 3. You are taking care of an ARDS patient whose plateau pressure is 40 centimeters of water. In order to decrease the plateau pressure, which of the following ventilator changes would be made? A. Suction via endotracheal tube. B. Decrease the tidal volume. C. Decrease the PEEP. Or D. Increase the tidal volume. And the answer here is B. Decrease the tidal volume. Let's talk about plateau pressure. This is the pressure that is essentially left over in the lungs when they're fully inflated and there's no airflow. This is during the inspiratory hold period. So in a person who's breathing room air, they take a deep breath in and they hold their breath. It's the measurement after they have held their breath. And in a vented patient, it's the time after the tidal volume has been delivered to them. And plateau pressure is a measure of static compliance, or the compliance of the lungs, not to be confused with dynamic compliance, which is a measure of the airways. So it would make sense that patients who have some kind of pulmonary injuries or problems involving the lungs, such as pneumonia or ARDS, will have a decrease in static compliance since it's measuring the pressure and the elasticity of their lungs. So if you have a high plateau pressure, you want to decrease the tidal volume to make that plateau lower. And this is going to be one of the treatments in our ARDS patients. Question number 4. You suspect a left-sided tension pneumothorax in your patient. A typical assessment of this patient will include A. Tracheal deviation to the left and absent breath sounds on the left side. B. Tracheal deviation to the right and absent breath sounds on the left side. C. Tracheal deviation to the left and adventitious breath sounds on the left side. Or D. Tracheal deviation to the right and adventitious breath sounds on the left side. B. Tracheal deviation to the right and absent breath sounds on the left side. So if you have a left-sided tension pneumo, is that going to push your trachea towards the left side or towards the opposite side? It's going to push it towards the opposite direction. Also, adventitious breath sounds are abnormal breath sounds such as wheezing, crackles, and rhonchi, so we're not going to hear that on the affected side because we're going to hear nothing on top of the pneumo. So a tension pneumothorax is a very serious type of pneumo where air accumulates in the pleural space, but it cannot escape. And since it can't escape, the pressure ends up compressing and collapsing the lung and the heart, which can be life-threatening if not treated quickly. And if you look at the picture down below, that air has collapsed that lung and it is compressing both the lung as well as the heart. And what you see is tracheal deviation to the opposite side of the pneumo. Now there is air in the pleural space that's occupying where the lung should be, so you're not going to hear anything on auscultation. And you're also going to have signs and symptoms of hemodynamic compromise, such as hypotension and tachycardia, because think about it. The heart is being compressed by that tension pneumo and it can't pump very well, similar to kind of like a cardiac tamponade picture. You'll also see some distended neck veins and a mediastinal shift as well. Now, what's the treatment? You either want to needle decompress or put in a chest tube as soon as possible, since patients with tension pneumos will be unstable and they can potentially even PEA arrest. So this is a very timely emergency. Question number 5. In a patient with ARDS, which contributes to the development of atelectasis? Is it A, decreased pulmonary vascular resistance and hypoxemia? B, increased pulmonary compliance and hypoxemia? C, loss of surfactant and interstitial fluid accumulation? Or D, mucosal edema and mucus plugging? And the answer here is C, loss of surfactant and interstitial fluid accumulation. So in ARDS, or acute respiratory distress syndrome, there is damage to lung endothelial cells. And this is going to result in a loss of surfactant and interstitial fluid accumulation. And ARDS patients will have changes in lung vascular tissue that will result in increased lung edema and decreased lung compliance. And we'll talk a little bit more in depth about ARDS on the next slide here. ARDS is going to be a huge part of the respiratory section on the CCRN. And I know that everyone that was a nurse through COVID, unfortunately, probably knows ARDS a little bit too well. I know I do, and I'm sure that we're all still scarred to some extent from it. So thank you to everyone who fought through these tough times and made a difference in all these patients' lives. And if you weren't a bedside nurse through COVID, thank you for the difference that you're making every single day. Anyways, I digress, but let's talk about ARDS. ARDS is a massive inflammatory response which results from some kind of precipitating event or injury. Some examples can include sepsis, trauma, pneumonia, but there are many more. And this massive inflammatory response results in damage to both type 2 alveolar cells as well as capillary endothelial cells. Now, we don't need to get into the super nitty-gritty of these cells, but I do want you guys to know a little bit about them. So the type 2 alveolar cells are responsible for production of surfactant, and for that reason, when they're damaged, there is decreased surfactant production, and this results in massive atelectasis and alveolar collapse. And now the capillary endothelial cells are responsible for keeping capillary permeability. So when both capillary endothelial cells and these type 2 alveolar cells are damaged, the result is tremendous. It's alveolar edema, alveolar collapse, and refractory hypoxemia, which is a hallmark sign of ARDS. Some clinical signs of ARDS include tachypnea, tachycardia, progressive refractory hypoxemia, which means that the FiO2 is increased to 100%, and despite this, hypoxemia is still present. And in the case of ARDS, this refractory hypoxemia is due to a pathologic shunt where blood goes through the lungs, but it doesn't get oxygenated. And the treatment for this shunt, which is causing this hypoxemia, is administering oxygen and PEEP, or positive end expiratory pressure. And the PEEP helps to recruit alveoli and keep them open. Going back to the clinical signs that you'll see in these patients, they will absolutely have crackles and a high PaO-P because they are drowning from the increased capillary permeability and alveolar edema. And initially, similar to status asthmaticus, their ABGs in the earlier stages will be consistent with respiratory alkalosis since they're working hard to breathe and they're tachypnic, so they're blowing off a ton of CO2. However, as ARDS progresses, you will see respiratory acidosis because they're going to get tired, they're going to start retaining CO2. And you can also see metabolic acidosis, but this is a secondary effect. Lastly, their chest x-ray in the progressive stages will be a whiteout from the bilateral pulmonary infiltrates. Of note, a normal PF ratio is greater than 300. A PF ratio of less than 200 is consistent with ARDS, and a PF of less than 100 is consistent with severe ARDS and a 45% mortality rate. So what is our treatment going to be for these ARDS patients? It's going to include mechanical ventilation, and this is usually required within 48 hours of diagnosis because these patients just tire themselves out and their work of breathing gets so labored. So we need to intubate them in order to take that work off of them. And once we do, we want to make sure that we give them low tidal volumes. You have to know that we usually give tidal volumes of 4 to 6 milliliters per kilogram of predicted body weight for these patients. We do not give any more than that. As we've talked about, we are going to give PEEP. These patients need PEEP in order to increase alveolar recruitment and treat that refractory hypoxemia. We want to keep those alveoli open. We want to improve gas exchange. We do, however, need to be careful with increasing PEEP sometimes. You have to watch out for things like barotrauma or decreases in cardiac output and hypotension. When this does happen, you want to keep the PEEP because they're dealing with respiratory issues, but what you can do is treat those decreases in cardiac output, treat the hypotension with pressors. And we want to keep our plateau pressures less than 30 centimeters of water. And remember, we can lower our plateau pressures by decreasing our tidal volume. And we don't want the tidal volume to be more than what value? Not more than 4 to 6 milliliters per kilogram. We can also prone these patients to increase the perfusion to the lungs, which will in turn increase your P to F ratio. We can also use NMBAs, neuromuscular blocking agents, or paralytics in order to keep the work of breathing down and let the patient be synchronous with the vent. And as a last resort, these patients can go on VV ECMO in order to receive full pulmonary perfusion support. Question number 6. A patient develops tachypnea and chest pain one day status post right hip replacement. She also has pain in her right calf. Her heart rate is 116, respiratory rate of 32, temperature of 38.1, and blood pressure of 112/68 with a MAP of 83. You should prepare for which of the following? A VQ scan to rule out pulmonary embolism. B, CT pulmonary angiography scan to rule out pulmonary embolism. C, ultrasound to rule out DVT. D, D-dimer and coagulation studies to rule out pulmonary embolism. And the answer here is B, CT pulmonary angiography scan to rule out pulmonary embolism. A pulmonary embolism is a partial or complete obstruction of the pulmonary arteries by either a venous thromboembolism or another substance such as fat or air. And no matter the substance, either way, this clot results in a VQ mismatch, V standing for ventilation and Q standing for perfusion. Now, the lungs are able to be ventilated, however, they're not being perfused because of that clot. And this results in impaired gas exchange, which leads to alveolar dead space. Some risk factors include immobility, surgeries, major trauma, bone fractures, or clotting disorders. And the signs and symptoms include all of these listed here. Most importantly, tachypnea, dyspnea, chest pain, and hypoxemia. If the pulmonary embolism is a result of a fat embolus, the patient will likely develop petechiae or a petechial skin rash. You can also have hypotension, shock, or cardiopulmonary arrest with massive PEs. The gold standard for diagnosis is going to be a CT-PA scan or a CT pulmonary angiography scan. You can do a VQ, but it might not yield the most accurate results compared to a CT-PA. And you can also do a D-dimer, but again, it's just not sensitive enough for a PE. Treatment for patients with a pulmonary embolism are going to be anticoagulation. So generally heparin, warfarin, Lovenox, some other anticoagulations can be used as well. But for patients with hemodynamic compromise, fibrinolytic therapy will be indicated. So we can give alteplase, similar to a stroke patient, but a little bit slower and without as strict of parameters. We can also do something called ECOS, which is catheter-guided thrombolysis, directly injecting alteplase and heparin into the clot to dissolve it. Question number 7. When assessing a patient who has a chest tube, the nurse notices that fluid in the water-sealed chamber rises during inspiration and falls during expiration. These movements are an indication of A, tension pneumothorax, B, normal pleural pressure changes, C, increased intrathoracic pressure, or D, a pleural air leak. The correct answer is B, normal pleural pressure changes. So the active fluid rising in the water seal chamber during inspiration and falling during expiration is known as tidling, and this is a normal finding with chest tubes. There are two types of chest tubes. There are pleural or mediastinal chest tubes. The pleural chest tubes remove air, blood, or serous fluid from the pleural space to promote lung re-expansion and help restore that normal negative pleural pressure. You'll see pleural chest tubes placed following thoracic surgeries, but also for patients with pneumothorax, hemothorax, pleural effusions, or empyema. There's a lot of different indications, but they are all respiratory and pleural in nature. On the other hand, you have mediastinal chest tubes, which are not placed in the pleural cavity. They are used to remove serosanguinous fluid from the pericardial space. Usually this is following cardiac surgeries. They want to prevent the development of cardiac tamponade, and they have nothing to do with lung re-expansion. Their only goal is to remove that extra fluid from the operative site. Let's talk about managing that chest tube. So you always want to keep the drainage collection chamber lower than the chest, even during transport. You do not want to have any dependent loops in the tubing, and you do not want to clamp unless you have to, because clamping cuts off that negative pressure to the lung, and the lung could potentially recollapse. So you only want to clamp when you're changing the system, if it accidentally got disconnected, or if you have a physician order to clamp. Just as I mentioned in the last question, when it comes to the water seal chamber, tidling, or when the fluid rises with inspiration and falls with expiration, that is a normal finding. So tidling is normal. However, if you have continuous bubbling in that water seal chamber, that is going to be abnormal. The continuous bubbling signifies an air leak. And the only time in which an air leak would be an expected finding is when a patient has a pneumothorax, because they have air in that pleural space, right? I'm going to repeat it one more time. The only time that bubbling is going to be normal is when the patient has a pneumothorax. Once the bubbling stops, that's when you know that your pneumo has resolved. Question number 8. A patient is having an acute asthma exacerbation. Their initial ABG was a pH of 7.45, a PaCO2 of 28, a PaO2 of 142, and a bicarb of 22. Now the patient is tiring with impending respiratory failure. You would see A, respiratory alkalosis, B, hypercapnia, C, hypocapnia, or D, metabolic acidosis. We have to read this question very carefully because it is a tricky one. So it's showing us an ABG here, and it's telling us about a patient in an acute asthma exacerbation, but it is asking us a question about impending respiratory failure, and they mean late respiratory failure in this case. So which of these choices would be a sign of late respiratory failure? It's going to be B, hypercapnia. So late respiratory failure occurs when the patient is tiring and they start retaining CO2. And a CO2 of greater than 45 is known as hypercapnia. When they're hypercapnic, they are in a lot of trouble. That is an ominous sign. For the exam, you'll want to know which conditions are going to be associated with which acid-base imbalances. And if acid-base imbalances scare you and you feel like you can never understand them, just stick with me here. So something that I personally like to do when it comes to these questions is really just visualize your patient. It helps understand what is going on. And to review the very basics here and simplify this to the bare bones, we breathe in oxygen, and then your body exchanges the oxygen for carbon dioxide in your lungs, and we breathe out carbon dioxide. So we breathe in oxygen, we breathe out carbon dioxide. So let's start by visualizing a patient together. Let's just say you are taking care of a post-op patient and you want to treat their pain adequately. So you give them a Norco 10, you give them 50 of tramadol, you give them their scheduled gabapentin, and maybe you sprinkle in a little 0.5 of Dilaudid in there. You peek in on them a little bit later and they do look comfortable, but they are out. Now, when you're looking at this patient, are they going to be breathing fast or are they going to be breathing slow? They're going to be breathing slow, maybe even too slow, or perhaps, but hopefully not, even apneic. And now if they're breathing at a respiratory rate of 5 breaths per minute, let's just say, they are not going to be able to eliminate that carbon dioxide adequately because their body is producing this carbon dioxide, but they're not breathing it out. So they're going to retain it and it's going to build up in their blood, hence these patients having a high PaCO2, which is greater than 45. Now think about this in terms of respiratory failure. The reason that late respiratory failure will cause respiratory acidosis is because with late respiratory failure, your patient is tired. The body has been keeping up with the respiratory failure by churning out all these compensatory mechanisms, but at a certain point, the body can only do so much until it just cannot keep up with the demand. So it tires out, it starts giving up. I know that we've all seen this before. And that's when you start breathing slow, you decrease your level of consciousness because your patient is developing hypercapnia. On the other hand, we have respiratory alkalosis. And this is going to occur with a patient who is hyperventilating and blowing off a ton of CO2, making their PaCO2 less than 35. So when are you going to see a patient breathing fast? Well, you'll certainly see it in early respiratory failure when you're hyperventilating due to your body's response to some kind of insult or injury. And you'll see respiratory alkalosis with anxiety or severe pain, fever, sepsis. I know this sounds super straightforward, but also if your tidal volume or your respiratory rate settings are too high on your ventilator, the patient might be blowing off too much CO2. So remember, hypoventilation, you're retaining CO2, you'll have a respiratory acidosis since carbon dioxide is an acid. And in hyperventilation, you're blowing off all that excess CO2. So you won't be left with a lot, and you'll have respiratory alkalosis. Now in metabolic acidosis, either your body produces too much acid or your kidneys just can't get rid of that acid. So in acute kidney injury, your body is not able to get rid of excess acids, so they stay in your system and they cause metabolic acidosis. You can also see metabolic acidosis in diabetic ketoacidosis, which is going to be a big one, aspirin overdose, lactic acidosis, or with electrolytes. So if you're hyperkalemic or hyperchloremic. And I do have a funny way of remembering which electrolyte abnormalities go with which metabolic imbalance. And I did not come up with this myself, but someone told me this and it has always stuck with me since. So when you take acid, you get high. When you take acid, you get high. So hyper electrolytes cause acidosis, high acid. So hyperkalemia and hyperchloremia cause metabolic acidosis. This does apply to other electrolytes as well, but potassium and chloride are the most common ones, which will cause metabolic acidosis. On the other hand, we'll talk about metabolic alkalosis, and this is when there either is too much acid removed or when there's just an excess of bicarb in the blood. And the most acidic part of our body that I can think of is our stomach. we have tons of acid in our stomach. So when we get rid of too much of that acid, we're left with, well, not a lot of acid, right? So we are going to be more alkaline in that case. So if you vomit, or if you have emesis, an NG tube dissection, or if you're abusing antacids, those can all cause metabolic alkalosis. And let's think back to our little phrase here. Which electrolytes cause metabolic alkalosis? So when you take acid, you get high. So we're going to apply the opposite here. For alkalosis, you will have low levels of electrolytes. So hypokalemia and hypochloremia. Question number 9. Which is an anticipated finding of a patient with status asthmaticus? A, metabolic alkalosis. B, tension pneumothorax. C, bradycardia. Or D, dehydration. The answer here is D, dehydration. So dehydration occurs because of the insensible fluid loss from the patient's rapid respiratory rate. Moving on to our last question here, question number 10. Which of the following statements about lung compliance is true? A, an increase in the peak inspiratory pressure will decrease static compliance. B, a decrease in compliance increases the work of breathing. C, static compliance is decreased with an asthma exacerbation. Or D, the plateau pressure is used to calculate dynamic compliance. Moving on to our last question here, question number 10. Which of the following statements about lung compliance is true? A, a decrease in compliance increases the work of breathing. B, an increase in the peak inspiratory pressure will decrease static compliance. C, static compliance is decreased with an asthma exacerbation. Or D, the plateau pressure is used to calculate dynamic compliance. And the answer here is A, a decrease in compliance increases the work of breathing. In short, you can think of compliance as the degree of elasticity of tissue. So a decrease in compliance will decrease the elasticity, or you can think of it as increased resistance or stiffness. Now, dynamic compliance is a measurement of the elastic properties of the airways, and it's calculated with peak inspiratory pressure. So patients who have pulmonary problems that involve mainly the airways, such as an asthma, will have a decrease in dynamic compliance, but their static compliance remains normal. Now, static compliance is a measurement of the elastic properties of the lungs, and it's calculated with plateau pressure. Patients with pulmonary problems that involve mainly the lungs, for example, pneumonia or ARDS, have a decrease in static compliance. However, sometimes in the cases of ARDS, their dynamic compliance may also decrease as the lung pressures may transmit up to the airways and become a little bit less compliant. So if we want to go back and go through the answer choices after talking about this, choice B is not correct because an increase in the peak inspiratory pressure will decrease dynamic compliance. Choice C is not correct because asthma decreases dynamic, again, or airway compliance, not static compliance. And choice D is not correct because dynamic compliance is calculated using the peak inspiratory pressure. So A is going to be our correct answer here. All right, we have made it to the end. Make sure to look out for my respiratory part 2 lecture. And if you liked this video and found it helpful, please like and subscribe to my channel to get updates of new videos dropping. I would greatly appreciate it. And always let me know if you have any questions. I would be more than happy to help. If you did get any questions wrong, do not fret. Just go back and review the content, come back until you get the question right and you can understand why. And this is all information that you want to have mastered going into the CCRN. You can absolutely do this, so good luck. You've got this. Thank you everyone for watching. Nurse Jenny signing off for Nurse Life Academy. Have a good one.